Hello everyone. This chapter we're going to talk about patient record requirements. Health information can be either a physical paper record or chart. It can be an electronic form, or it can be an abstract of patient-specific information. So like an abstract meaning like a pull of a bunch of different pieces of that patient's information. Whatever format it's in, it serves as the healthcare provider's legal record of that patient's treatment or their care. So because of that, it's subject to a lot of legal requirements. Even though a lot of facilities use electronic records now, most of the legal requirements reference only paper health records. The laws haven't updated or caught up to how fast the technology has changed. Okay. So before we can understand the legal requirements dealing with health records, we have to first know all of the functions and uses of them. Because there's so many functions, you'll notice that people call the health record all kinds of different names, like medical record, hospital chart, outpatient record, clinical record, electronic health record, and the list goes on. So all of those things are talking about the health record, okay, which is a document that contains a complete and accurate description of a patient's history, their condition, any diagnostic or therapeutic treatment they've received, and then the results of that treatment. It also includes their detailed personal, medical, financial, and social data. It serves both clinical and non-clinical uses. It's a chronological document, right? It goes, through time of their clinical care. It's created at the time the care is given and is used by doctors to communicate with each other about the patient's care. Okay. In addition to direct patient care, health records are used as the main source for research purposes, for public health monitoring, to control the spread of disease, and for quality improvement activities. So to make sure the care is appropriate and adequate, okay? Then we have some non-clinical uses, such as for billing and reimbursement, or for employers to verify the extent of an employee's disability, and then lastly, as the legal document of care. The health record is kind of considered like the backbone of any professional liability action because it's the only thing that can prove what did or did not happen and if the standard of care was met. Okay. All right. So kind of like I said earlier, the health record was traditionally paper-based, but now most facilities use electronic health records, or at least some type of hybrid record, which is part paper, part electronic. But whatever the medium is, the legal health record is the business record made by the healthcare provider or the organization that details the patient's episode of care. Okay. There is not one source of law that addresses all of the legal requirements for health records. It's all of these sources here. So regulatory, statutory, professional guidelines, accrediting, and institutional. So these are all separate sources, but they have to be reviewed together to have like a full understanding of the legal requirements. I guess like a puzzle, which is why they did this graphic here. Okay, first we're going to go over statutory provisions. So these are the first things you look at in any review of legal requirements for health records because of their importance in the legal system. So these are federal or state laws or municipal codes. So for example, there's a federal law. You don't need to know the specifics really, but it has to do with Medicare that states a hospital is an institution that maintains clinical records on all patients. But it doesn't say or define what that clinical record has to contain. So you have to look other places to get the full picture. So like what has to be contained in the record? Some states do define the content in their statutes, and it's usually in the context of hospital licensing, such as the example there, the Tennessee Medical Records Act of 1974. But not all states do. Just depends. Okay, sometimes a statutory provision will give certain powers to the executive branch agencies that do the licensing for healthcare facilities, such as the power to enforce rules and regulations that govern the health records. Okay, so these regulations are found at both the state and federal level and can be just a general statement that the health record has to be maintained. It can be a broad list of requirements, or it can be very specific requirements. Okay, some states use the CMS, the Centers for Medicare and Medicaid requirements, and a couple of states use the Joint Commission accreditation standards. Again, it just kind of depends state to state. Okay, so here's just an example of a detailed regulation from CMS. The CMS conditions of participation. So the medical record must contain information to justify admission and continued hospitalization. That's that medical necessity, right? It has to support the diagnosis and describe the patient's progress and response to medications and services. Must be legible, complete, dated, timed, and authenticated in written or electronic form by the person responsible for providing or evaluating services. So I think that's actually a pretty good one. Okay, so accrediting standards do not have the force of law, right? The one we just talked about did. These do not have the force of law. They're used to establish what the standards of care are in negligence actions against healthcare providers. So at least 2 states have adopted accreditation standards as their governing regulations. There are a few voluntary accrediting bodies in healthcare. The most well-known are Joint Commission and the AOA, the American Osteopathic Association's Healthcare Facilities Accreditation Program. The last one, the Det Norsk Veritas, is a newer organization. But all 3 bodies have been granted what's called deeming authority by CMS to conduct accreditation surveys to make sure the facility is compliant with all of the standards. Okay, so this deeming authority means that if the healthcare facility is compliant with their standards, then the facility would be considered compliant with the federal government's CMS conditions of participation. Okay, so in case that sounded confusing, the 3 that I mentioned on the last slide, Joint Commission, AOA, and Det Norsk, CMS has basically said, okay, y'all are basically following what we follow, and so if y'all deem that this facility is good to go, then they're good to go in our eyes too. Okay, being accredited by one of these organizations, again, it's not required, but it basically just to help, just helps their reputation, right? And their public image, makes them more competitive. Also gives them the ability to borrow money easier. So each of these organizations has very detailed and specific requirements on how the facility has to maintain their health records. There are other accrediting bodies out there as well that are usually more specialized. And I think there's a table in your book that goes over them. But again, like being accredited is almost more of a, you should come to my hospital because we're accredited instead of going to that hospital down the road. They're not accredited kind of thing. All right. Healthcare facilities can also create their own standards or adopt accreditation standards from another accrediting agency. So these are called institutional standards. like accreditation standards, these do not carry the force of law. They just serve as a guide for how to keep the health records, okay? And then on top of all those organizations, allied health professional organizations such as AHIMA, the American Health Information Management Association, they all also have guidelines that go over, the content of health records. So the health information managers use these a lot to make sure their facility is keeping the records the best way, because really the professional organizations like AHIMA, that is so specialized in records, so they're going to know the best ways to be keeping them. Okay. All entries in the health record have to be authored and authenticated. Okay, so authorship tells us which healthcare provider made the entry, whether it's in writing or by dictation, by keyboard, keyless data entry. Okay, authentication confirms the content of the entry by either a written signature or initials or a code. Okay, so the healthcare provider is supposed to double check their entry and then sign to say, yes, this is accurate. Okay, now because of electronic health records, authorship has gotten a little more complicated. The copy and paste function in EHR systems can actually misidentify who's making the entry. It can accidentally attribute it to whoever made the original entry. There's also the possibility of pasting the information into the wrong patient's chart, or accidentally adding services on dates when they didn't have a procedure done, okay, or accidentally duplicating an entry that's no longer accurate for that patient. So to reduce the risk of those things happening, there has to be some policies and procedures in place that specifically talk about the copy and paste function, and train the staff properly on it, because they can do internal audits on who's using the copy and paste function to see if the staff is being compliant. Okay, the use of rubber stamp signatures is not allowed by CMS, but rubber stamp signature, of the doctor's signature, where the nurses can just go stamp, yep, the doctor did this, yep, doctor did that. CMS does not allow this, but some state or local licensing organizations do permit it. But they have to have strict rules saying that only the doctor whose name is on the stamp can use it. But I'll tell you right now, I've been in facilities where that's not the case. So take that for what it's worth. CMS only accepts physician signatures that are handwritten or electronic or by fax. Okay. Without a complete health record, the doctors can't properly render care, right? They need to know the full picture to treat a patient properly. And also, if there's a lawsuit, it would be very hard to defend yourself if the health record doesn't have everything you're saying you did or didn't do in it, okay? There was a lawsuit where 2 patients received cornea transplants from a person that had passed away, and both patients ended up getting ophthalmitis, like an infection in their eye, and lost their sight. So it turns out the lab results on the deceased donor patient that showed this person had an acute infection wasn't made a part of the record. So they just went ahead and harvested the organs. So the hospital was held liable for medical malpractice, because that lab results should have been put in the record. So they would have seen, wait a minute, this patient had an infection. We can't use these organs, right? Okay. In order to ensure completeness, only the author of the entry can authenticate it. So it has to be made by someone who was actually there and witnessed the event at or around the time this event happened. Okay, that's known as contemporaneous. You also have to have an entry for medical advice through email or text or any other electronic means. When it says medical information does not need an entry, that's referring to like general medical information that's not specific to the patient and can be found on like a forum or something. Okay, and then reliability is super important for doctors and nurses to give the best quality of care possible. Obviously, for the patient, but also in order to meet accreditation requirements and for legal defense purposes. Okay, the health information department comes into play here because they can perform concurrent. So while the patient is in the facility, still being treated, and post-discharge chart reviews to make sure everything is signed and documented properly. And if it's not, then they have to get the physician to address it right away and fix any deficiencies so that, in case there is a lawsuit, it doesn't look like the doctor came back much later and added information into the chart. That would look bad. In the eyes of the court, if it wasn't documented, it wasn't done. Okay. There was a case where a doctor had given an order to like the nursing staff to watch the condition of a patient's toes. They had a cast on to make sure that they had good blood circulation. And there was like a 7-hour period where the nurses didn't record any notes saying that they observed the patient. And the patient ended up having to have their leg amputated. So the nurse testified, well, we don't always write down our observations every time a patient's checked, if it's normal. But the court found in favor of the patient because it wasn't documented, even though the nurse says they did check them. It wasn't documented. So according to them, it wasn't done. All right. Okay, so what happens if someone makes a mistake when making an entry in the health record? This happens, and that's okay. How to correct a paper-based record? You draw a single line through the error. You don't want to, scratch it out, white it out, or anything like that. You write error besides it, date, time, and initial it, okay? Only the person who made the error should correct it. Someone else should not come behind them and do it themselves. So if you were to find an error, you would just let that person know that made the error, hey, you need to go fix this. That's for paper-based. In an EHR, it's the same idea, okay? You do an addendum to the record and reference the original entry. Standards organizations do have like guidelines, like how to follow. Every facility is going to have a policy and procedure on what to do if, in this case, if you make a mistake. Okay. All right. Let's see. All right. In paper-based or electronic health records, you should never delete or get rid of anything from the record because this could compromise it. Doctors and nurses need to be able to see everything to make the proper decisions for a patient's care, right? Say you get a copy of your health record and notice something's not right or it's not complete. Under HIPAA, you can request for the facility to make an amendment to your record. If they agree, they'll let you know and add, the amended information, but they can deny the request for a limited number of reasons. They do have to give written notice to the requester, if they do deny it, what their reasoning is. So, the HIPAA privacy rule is kind of like the base requirement here, but states can also make laws regarding this. So if the state law is more strict, the facility has to meet the HIPAA and the state requirements. And really that's a good general rule of thumb. Whatever is the most strict, go by that. Okay. Now, what happens when a person's record, what happens with a person's record after they leave a facility or after they die? Do they just throw it away? Obviously not. There are record retention policies that determine how long records have to be kept and in what form or what medium. There's what's called a record retention schedule, which is a document that specifies what information has to be kept, for how long, and in what manner or medium. And by medium, I mean like paper, microfilm, discs, electronic, like archival systems, all of that, okay? Some states have specific timeframes that differ from federal regulations, and also the timeframes can differ for patients that are a minor or that have mental disabilities. So on the federal level, CMS requires facilities to keep the record for whatever the state's statute of limitations is. If they don't have one, it's 5 years after the patient is discharged. The statute of limitations in contract and tort legal actions can also influence the retention decisions because, say a hospital gets rid of a chart after 5 years, but the statute of limitations on a patient being able, to bring that lawsuit isn't up. Say they have 10 years and they file a lawsuit, they are going to have no record to try to defend themselves with. So this could be a problem and has been a problem before in lawsuits. So again, like I said, you always want to go by whatever the strictest thing is, okay? All right. Business-related records have retention requirements also. So things like accounting and payroll documents, compliance and quality-related documents, and then sales records and correspondence. These requirements are based on state and federal statutes and regulations, and then also include both paper and electronic forms. Facilities also have to keep records showing that they were in HIPAA compliance for 6 years. So things like audit and monitoring results, internal investigations, hotline reports, documentation of employee training, any self-disclosures, things like that. So the facility would want to keep this in mind when they're making a record retention policy. All right, AHIMA and the AHA, the American Hospital Association, both recommend keeping records for 10 years. And I think most facilities go by this number. So for adults, it's 10 years from their last visit. For minors, it's 10 years after they've turned 18. Okay, so if a 10-year-old is being seen, they would have to keep their record for 18 years after their last visit, right? So until they turn 18 and then 10 years after that. Most facilities don't keep like just paper records anymore. They do have, like I said, either hybrid or electronic formats. So it takes up way less space and it's a lot easier to find than trying to like dig through boxes of paper, right? Already touched on what the policy should address, but they should include how the record is created and can be retrieved, what has to be stored on it, what has to be stored, and what the retention period is, okay? Okay, something kind of new that is helping to combat the increased cost of the legal discovery process of EHRs is Enterprise Content and Record Management, or ECRM. This gives a more systematic approach to e-discovery requests, and it makes it just more like a streamlined process, so like easier to find records. Okay, we're not going to go too much into that. Okay, all of that to say there's no one answer for how long a facility should retain records. 5 to 10 years is the average, but each facility has to look at their own needs and costs, what they can afford, how much room they have to store stuff, or what the costs are to store records off site, things like that. Okay. Last topic we're going to talk about is the destruction of records. So you can destroy records in 2 instances: in the ordinary course of business or due to a ownership change or a closure. So when it's done in the ordinary course of business, every policy should have, every facility should have a policy for record destruction that includes the method of destruction. So burning, shredding, dissolving in acid, destroying the medium. Okay. It also should include the laws that require the hospital to make an abstract of patient data before destroying their record, if your state has that law. And then also some state laws may require you to notify the patient or the licensing authority before you destroy the record. Okay, so your policy should have all of that in it. The HIPAA security rule also goes over all of the requirements for this as well. Okay, so whatever method is used to destroy the health record, the biggest concern is still keeping the contents of the record confidential, as required by the HIPAA privacy rule. If you don't, you can face civil fines and punishment. Okay, a lot of facilities use commercial vendors to destroy the records, like shredding companies. The facility has to make sure that the contract specifies what the method of destruction is, what safeguards the vendor's taking, the indemnification process if there is an unauthorized disclosure, what happens, and the certification process, just saying that the destruction was done properly and it was certified. Okay. All right. You have to specify the method in the policy. I kind of already talked about that. Paper, for paper, shredding, burning, blah, blah, blah. Electronic media, magnetic degaussing or overwriting non-sensitive data, destruction of backup tapes, etc. The timing after the retention period has expired, and then there has to be a certificate of destruction. It has to include what documents were destroyed, by who, and what method was used. This certificate has to be kept forever. You don't destroy this certificate of destruction. Okay. Okay, and then here's the other instance: if the destruction due to ownership change. So if the doctor is selling his practice to another doctor, or is retiring, or dies, the health data and records are considered property assets and are included in the contractual terms that were agreed on. So in the contract of a sale, it would say what happens to the records. Okay, and I don't know, I think I might have told y'all this, but I remember I worked for a doctor who his partner retired and didn't sell his practice or anything, and so he took all of the paper records to his house and stored them in his garage until the retention period was up. Okay. Lastly, if a healthcare facility closes or a medical practice dissolves, the healthcare provider is responsible for the health records. Okay, I should have used my example here. Some states say that if they should transfer the records to another healthcare provider. Others say they should deliver the health record to like the state licensing authority for storage. It just depends. If the healthcare provider offered any alcohol or drug abuse services, there are special like federal regulations for how to proceed because that's considered like highly sensitive information. And if the healthcare provider closes due to bankruptcy, there are also federal laws that specify like what to do in that instance. Okay, and that's all I have for y'all today. Hope y'all have a good week.